Thank you so much for your kind words, and it is indeed an honor to be among you all today in this very prestigious session. Thank you for the opportunity to be presenting to you on ocular surface diseases, the red flag signs identification, management, and referral. I have no financial interest in the mention of any of the products or procedures during the course of this talk here. So when you look at ocular surface diseases, you can sort of broadly categorize them into inflammatory or infective lesions of the ocular surface. They could be due to cicatricial diseases, which could be like due to OCP, due to SJS, or secondary to limbal stem cell deficiencies. They can primarily be because of malignancies, which can be either benign or malignant neoplasias. Yeah? And of course, what you would commonly see is degenerative diseases affecting the ocular surfaces, the dry eye disease, and conjunctival degenerations. Largely, most of what we would encounter in our cornea practice would fall under any of these categorizations. And I have specifically not placed trauma under this, because trauma is something which is acute and you would immediately interfere for its management here. So what are the red flag signs in identifying these? I have targeted this largely towards the theme of today's session being aimed towards comprehensive ophthalmologists here. So most of us would be seeing in our practice patients who are on contact lens wear here, especially as cornea specialists here. So contact lens associated red eye is something which we need to pick up early. And when we look at CLAIR, which is contact lens associated red eye, you'll need to differentiate whether it's because of an immune disease or because of is it because of an infective disease. So that would be primarily one. When you look at CLIC, contact lens induced keratitis, you'll have to know whether it is an infectious or an immune keratitis. So the signs here, largely when you look at immune keratitis, usually not associated with pain in the beginning. The lesions might be unifocal or multifocal and are peripheral here. And when you have a large amount of associated inflammatory signs of blepharospasm, more of conjunctival injection, pain, anterior chamber inflammation, you would bend towards the side of an infective. But primarily, we always do err on the side of on the side of doubt, giving the benefit of looking at it as an infective lesion and treating as an infective lesion. So your red flag flies high when you are a little scared. You're looking at a patient who's wearing contact lenses and is presenting to you with a CLIC. That's the time, if you're not confident, you probably would be happy to send it across or call your specialist to step in to give you expert advice on this. Another common feature which you would probably want to look at the ocular surface is the staining patterns which are induced by long-term contact lens wears here. So these staining patterns are wonderful telltale signs to tell you about the sufficiency of a particular fit, and these fits do tend to change over a period of time, especially in patients who are using contact lenses for a long period of time. Especially you have a large bracket of corneal ectasia patients who are on contact lens wear, and this is when you're going to look at the staining patterns when you are following them up. And when the staining patterns are particularly in the 3, 6 o'clock or the 9 o'clock or peripheral staining patterns, or if you're having diffuse staining patterns, that's going to tell you how the fit of the contact lenses has particularly changed. And that's when, if you are a contact lens practicing specialist as well, or if you're having an optometrist who's aiding you, you probably are going to ask them to step in and look at refitting these patients or modifying these lenses in your subsequent follow-ups here. Contact lens induced dry eye disease is another particular feature here, especially in a setting of an ectasia wearing contact lenses, and if there's an association of ocular allergy, that's going to be another red flag where you need to be treating this as well, because all these will be risk factors for an onset of infectious keratitis here. Gram-negative infections, acanthamoeba infections, and that said, even gram-positive infections are more common in patients who are in contact lens wear here. So that's another sign which needs to be identified and picked up earlier for prompt management or a referral if you're just a comprehensive ophthalmologist. Then scenario number 2 is something which we would see commonly is viral conjunctivitis or keratoconjunctivitis here. So it's always a tendency when you're worried in your conjunctivitis stays on for more than a period of 3 to 5 days here. And that's when generally tend to abuse with use of increase in your non-steroidal anti-inflammatory or add a low potency ocular surface steroid here. So that's something when you'll have to be cautious. The steroid abuse or an NSAID abuse here, and again, frequent topical use of fourth generation fluoroquinolones. That's something which commonly everybody resorts to when you see a conjunctivitis. I would simply start with less potent, or I wouldn't say less potent, but those antibiotics as that simple as chloramphenicol or polymyxin do fantastically well when you're talking about viral conjunctivitis or keratoconjunctivitis, because it's going to play only a prophylactic role in preventing a secondary bacterial infection here. So overuse or abuse of fourth generation fluoroquinolones, all these will be specific risk factors associated with large epithelial detachments when you're using them over a long period of time. Sometimes you do see viral keratoconjunctivitis depending upon the strain of the organism which is causing, where the virulence or the tendency to cause early epithelial detachments is again very high here. So again, this is another scenario which needs to be identified and looked at, and ask your cornea specialist to step in to help and manage. Otherwise, you would probably be complicating the ocular surface even further in these scenarios. Misdiagnosis is a simple simple conjunctivitis or an epithelial keratitis is also another common red flag scenario here, where you probably have missed the earlier peripheral or smaller dendritic patterns, and you're looking at it only when it's become a geographical ulcer here. So that's a particular warning sign, and you would not want to worsen the scenario in such a case here. We now move on to fungal keratitis. I think lots has been said by wonderful presentations which preceded this session here, so I'll just make it brief here. So clinical diagnosis is the key to the management of fungal keratitis. That said, it's refractory or recalcitrant fungal keratitis, where probably your microbiological detection methods is not helping you to enhance your clinical diagnosis. This is a scenario when you probably will have to stop and relook at your management modalities here. So that said, if you do have an access to a confocal microscopy, please do it on early, because you need certain clear spaces of the cornea, and you need the patient to be more cooperative for you to image better to pick up these fungal hyphae. And when you're able to do that, it is a fantastic methodology, and now it's an accepted methodology as an effective alternative to doing microbiological spear and cultures. When you look at those hyphae, then you know that you're dealing with you have a diagnosis in hand, and the morphology, depending upon the resolution and the clarity of your picture, also to a reasonable extent with your microbiologist stepping in, will be able to tell you if these are fungal hyphae filaments or you're looking at something like nocardia or some other filaments here. So that's an important clue here, where you're looking at a refractive scenario of fungal keratitis, because we know all these atypical scenarios could mimic one or the other, and a delay in diagnosis is worsening the morbidity and increasing further complications in these diseases here. So you would have nocardial infections, atypical mycobacteria, pythium, microsporidia, all of which can be mimickers to simple superficial or deep mycotic keratitis, and so that's going to be another scenario when your red flag will probably fly higher. Herpetic keratitis, epithelial, dendritic, and geographical, is something which I already referred to you about. So beware when your dendritic ulcer is going on into a non-healing geographical ulcer and is having a deeper stromal involvement. That's when you're probably going to be worried of these ulcers. Again, missing necrotizing viral and a misdiagnosis as a bacterial or a fungal stromal keratitis with thinning is a common mistake, and overloading the surface with antibacterial therapy, you're going to have a higher failure and increased chances of perforation in these cases here. Secondary infections would be particularly high in necrotizing viral, and if you don't pick them on early, again, you're going to have your fingers burnt here. Do not use steroids in a scenario of viral infections of the ocular surface in the presence of an epithelial break and epithelial ulceration here. Beware when you have a Hutchinson's positive when you're managing herpes zoster infections and herpes zoster ophthalmicus here. Recurrence is a chance, and frequent recurrences, stromal involvements, visual axis opacifications, all will warrant a need for urgent or looking at an alternative or enhancing your management modalities or looking at a referral in these cases. Again, misdiagnosis plays a significant role in this as well. Masquerades, recurrent pterygium, especially in elderly individuals, those with very poor ocular surfaces here. Chronic conjunctivitis is another masquerade here, which could mimic, which could mask surface neoplasias here. Recurrent chalazions is another scenario where you probably would miss malignancy of the meibomian gland ducts here. Actinic keratosis and other limbal lesions could be precursors to surface neoplasias here. Moving on to ocular surface disease, dry eye disease, especially in people who are cataract surgeons here as comprehensive ophthalmologists, then you probably look at this very nice elucidation of 5 disease subtypes described by the Corneal and External Disease Refractive Society, known as the CEDAR signs of ocular surface disease. So I look at the surface to see if you have an aqueous deficiency. It's easy to pick that up, and it's more worrisome in managing when you're dealing with the associated conditions which affect the lacrimal gland secretions, which have dysfunctions or destructions for the lacrimal gland, or any other features which will lead to aqueous deficiency. So you're going to be look at this when you're managing your cataract patients here. Goblet cell deficiency, so resulting in mucin deficiency, is a characteristic feature where you would be finding an evaporative dry eye disease, commonly seen in scenarios affecting the lid and meibomian gland dysfunction here. Red flag number 3 for ocular surface in cataract is not that all evaporative dry eye mucin deficiency presents as evaporative dry eye disease, where you do have conjunctival tissue destructions, as in chronic in trachoma patients and chemical burns and chronic anti-glaucoma therapies. These again will result in red flag signs here. And poor tear resurfacing and other what are known as co-conspirators were also ones which would be affecting your ocular surface here. So I'll just, the next few slides are just pictorial representations to red flag when you're looking at chronic SJS. I think most of this comprehensive ophthalmologists do not want to manage this, so that is something which always lands up in our practice here, so we don't worry. But this is a case which presents as chronic conjunctivitis. When you're looking at diffuse CIN here, it's going to be a very common masquerade or a mimic of chronic conjunctivitis, and you would miss. And this would be very well amenable to topical chemotherapeutic agents, and you would have wonderful results here. When you look at a chronic poor ocular surface with signs such as telangiectasia here, severe chronic ingestions here, then you're probably looking at cases of an acute SJS, a milder onset, and you would not want to miss that. OCPs are very easy to diagnose here, and especially when they come to you, and the picture lower down here, that when you're seeing them early on as just chronic conjunctivitis in you involving the phonesis, look for phonexes, foreshortening, subepithelial fibrosis here, and lid margin keratinizations and the lid margin telangiectasias, which will all be telltale signs which will raise your red flag. Peripheral dendritic, thick coarse dendritic ulcers in the elderly patients, and would be a warning sign to say that these could occur in patients like SLE and do have neoplastic, systemic neoplastic diseases here. Again, these are classic pictures when they are a full-blown Stevens-Johnson's. Usually it's not missed, but when you have a minor SJS, it could commonly get missed by practicing comprehensive ophthalmologist. So I'll just conclude with this, that even giving injections of intravitreal avastin, bevacizumabs, can lead to precipitation of metaherpetic ulcerations of the ocular surface. So that's another red flag, considering that intravitreal injections are quite high on here. So that's something you would look at when you're managing the surfaces of diabetic patients here. Thank you again for your patient listening.
Thank you so much, ma'am, for that very eloquently put talk and covering very nicely all the very important signs for referral. Dr. Manisha, would you like to add anything?
been described by Dr. Vanathi. And yes, red eye is something I think as comprehensive ophthalmologists and even as cornea specialists, which we are dealing very much in our practice. And having these red flags, we should be able to come up to some diagnosis which will eventually help in managing these patients. So thank you, Dr. Vanathi, for such a comprehensive and wonderful presentation again.